So we are live. We are live for everybody online. We are here in Columbus, Ohio. We haven't been here since 2022, so it does feel good to be back. We have Carina Siracusa, and Carina Siracusa is a pelvic floor specialist. She is right here next to me. She is from Columbus, Ohio. She is from Ohio Health. She has done a lot in this community. She's often involved with our programs that we do here online, here in person, as well as online. She's done many virtual events with us since the unfortunateness of COVID. But I also want to let you all that today, our program is sponsored by Novartis Pharmaceuticals and TG Therapeutics, and we can't do these programs without them, so let's let them know that we thank them. Thank you. Dr. Siracusa, take it away.
Thank you. All right, and thank you again, Stuart, for having me. I love to talk about this topic. I'm going to be talking about pelvic floor physical therapy for the person with MS, specifically, some of the issues that happen, starting with bladder, but we'll talk a little bit about bowel as well. When you have MS and why some of those issues happen. We'll also talk about bladder issues when it's not MS, because what I always tell people is your pelvic floor had a life before you were diagnosed with MS. So you might have had kids before you were diagnosed with MS. You might have had prostate surgery before you were diagnosed. So we're going to talk about trying to tease out the things that could be related to your MS or could just be related to life and the life that you've experienced prior to your diagnosis. I do apologize. I'm coughing a little bit. I'm getting over a sinus infection. I am not contagious. I have a week's worth of antibiotics in me, so no worries about that. Just can't get rid of the crud that everyone seems to be stuck with. So I apologize for that. I am a doctor 2 times over, actually. So I have my doctorate in physical therapy, and then I've been a physical therapist for over 19 years at this point. But one of the things that I really saw in my life as a physical therapist was the fact that people really needed education, and that's why I love doing these events. We're not taught, especially about our pelvic floor, enough in school, in our medical appointments, and so I went back to school and I got my doctorate in education, so that's the other letters behind my name, and to help my patients. I also am a professor of physical therapy at South College, which is a hybrid physical therapy school out of Knoxville, Tennessee. So I live in Columbus. I'm employed in Tennessee and Ohio. I get around. And then I'm also board certified in both women's health or pelvic health physical therapy and oncology physical therapy. So I joked to my mom that I wanted to have more letters after my name than in my name, and I accomplished my goals. So I'm good. All right. So let's start with just talking about what are our pelvic floor muscles? Because there's a lot of questions a lot of times about what our pelvic floor muscles are, where are they, what do they do even, and so you're looking at the pelvic floor muscles right here. We all have pelvic floor muscles, whether you are a male or a female, you have pelvic floor muscles, and actually they are quite the same. The only difference between the male pelvic floor and the female pelvic floor is that in the female pelvic floor there are 3 holes, and in the male pelvic floor there's only 2. That's the only difference. And so a lot of people associate pelvic floor issues with women because women give birth to children through that 3rd hole. But men can have just as many bowel and bladder problems and just as many problems with their pelvic floor as women do. So our pelvic floor muscles, in the simplest terms, are the muscles that span from sit bone to sit bone and pubic bone to tailbone. So they basically form almost like a bowl in the bottom of our pelvis. So you're all sitting on your pelvic floor right now. And our pelvic floor muscles, I call them the 3 S's as far as their function. So sphincter, meaning they keep us closed. They keep us from pooping and peeing. So all of your pelvic floor muscles are actually working right now, unless any of you are actively peeing or pooping, which some people at home might be. Just turn your cameras off. But all of you are contracting your pelvic floor muscles right now. We also have sexual function behind our pelvic floor muscles. And then we have what we call the supportive function. So they support all of our pelvic organs. For women, they support the bladder, the uterus, and the rectum. And for men, they support the bladder and the rectum. These pelvic floor muscles are really important, but they don't get a lot of love. We talk about in physical therapy all the time, working your legs, working your arms, working your trunk, but we don't often pay attention to these muscles. Many of you may have heard of Kegel exercises, and Kegel exercises are kind of what the basic exercise for your pelvic floor, but there's a lot more to it in order for it to function well. And as I said before, you don't have to have had a child to have weak pelvic floor muscles. If you have weak trunk muscles due to your MS, your pelvic floor is weak, and we need to be working on it. So all of those muscles are connected. And so if you have weakness in one place and you're not working on your pelvic floor, you're probably going to have weakness there too. So here's a nice picture just showing the difference between, again, the male pelvic floor and the female pelvic floor. As you can see, they are very similar. So a lot of women, when they come in to see me as a patient, will tell me, oh, I was told to do Kegel exercises, but I was just told to do them after I had a baby. Well, yes, your pelvic floor is stretched out, it's tired, it needs a little love after you have a baby, but it always should be worked on. That's not the only time that we should be working on our pelvic floor. Similarly, for men, most of the time they hear about Kegel exercises or working their pelvic floor is after some procedures on their prostate. So whether it be prostate cancer or just what we call benign prostatic hypertrophy, when it just gets a little larger as you age, that's usually when they're told to work their pelvic floor, but they should be working it all the time. The reason for this is the pelvic floor is the floor of your core. How many of you have heard about your core muscles? Yeah, okay, yeah. There we always talk about them. If you've ever been to physical therapy, we talk about them a lot, right? So you have to think about your core as a pop can or a soda can, depending on where you are in the country. But if you think about a pop can when it's closed, you can put some pressure on that can and it's pretty stable, right? You can sometimes even drop it and nothing's going to happen to it. There's no liquid that's going to leak out. But as soon as you create a weak point in that can, any sort of pressure is going to cause the liquid to come out. And so for a lot of people, if they have weakness in their pelvic floor, if that's the can, the bottom of the can, when they cough or laugh or sneeze, they pee a little bit because it's pushing the liquid out. So the pelvic floor is the bottom of that can, if you think about it. The top of that can is your diaphragm. So the muscle up under your rib cage that when you breathe in and out, it helps inflate and deflate your lungs. Your abdominal muscles are the front of that core. Your back muscles are the back of that core. And then your oblique muscles, these muscles on the side of your trunk, those are the sides of the core. All of those muscles need to work together. So in many cases, it's not just about weakness of those muscles. It's also just about the fact that they're not coordinating well. They may all contract, but if they're contracting at different times, you're creating an imbalance. And that imbalance can lead to urinary incontinence or fecal incontinence, but it can also lead to things like constipation, the inability to get stool out. It can lead to things like back pain, because if the bottom is not supported, then the top has too much pressure on it. It can lead to things like not being able to take a big deep breath because your pelvic floor can't move as well with the rest of your trunk. So what we do a lot, and I'll get to kind of the physical therapy aspect of it, but what we do a lot in physical therapy is not just trying to make things stronger, we're also trying to make things more coordinated and make that effort more coordinated. Okay, so let's talk specifically about our bladder, because for many of you, your bladder might rule your life, right? You know where every bathroom in the city is, or, it wakes you up multiple times in the middle of the night. And so bladder complications of MS specifically can be really frustrating for a lot of people. And so we'll start with talking about what MS does to the bladder, but then we'll also, as I said before, talk about what's not MS, what might just be those pelvic floor muscles, or what might be behaviors that you might have adopted because of some of the problems with your MS, and then that leads to further bladder complications. Okay, so this is one of the reasons why I tout that everybody with MS should talk to a pelvic floor therapist at some time along your MS journey, because bladder complications are going to be experienced by 96% of people with MS. So only about 4% of people will not have anything wrong with their bladder, okay? But this is one of the reasons why we instituted the bladder care program at Ohio Health, where I see patients, because we almost every single one of the patients coming to our center was complaining of bladder issues. But the other problem is often bladder issues are not reported right away. And there's a couple of reasons that I see for this. One is especially women with MS. What I hear is, well, yeah, I had a baby, so of course I'm going to be incontinent. That is not a thing. Even if you had a baby, you shouldn't be incontinent. If you have MS, you shouldn't be incontinent. There is no reason to pee your pants, unless you want to, but we won't get into that. But there is zero reason why you should have any sort of bladder loss. And so lots of people just think it's normal. Or the other thing that I hear a lot is, well, of course I'm going to leak. I have MS. Also not true. Also not something that you have to live with. There's a lot of things that do affect your bladder because you have MS, but that doesn't mean that you have to live with leakage. It just means that maybe there's some modifications that we need to make. Maybe there's some extra exercises that you need to do. And sometimes there is some medications that you need to be on that will help with some of that bladder leakage. But from a pelvic PT standpoint, I usually work with the urologists and we figure out what combination of those things do we need to do so that you do not have to leak. The most common complaints that I see from my patients with MS, urgency, that you don't feel like you have to go, and then all of a sudden it hits you and you have to run out of the room because you feel like you're going to pee your pants. Okay, so the number one question that I ask when people tell me that is, have you ever peed your pants? Okay. Now, what I will see more often than not is that one time they had a really big leakage. It was very embarrassing. And so to combat that, to make sure that never happens again, they go to the bathroom the first time they feel that urge. Well, there's a couple of problems with that. So one, that first leakage, that first kind of bomb, the urine bomb, I call it, that gets dropped with patients, is that what MS does to your bladder is that it does decrease the sensation of your bladder. So you know how you have some numbness, you have tingling, you have funky feelings in your limbs or other parts of your body? It does that to your bladder too. So what happens is that you cannot feel your bladder filling up as efficiently as you used to be able to. So the thing that I hear from patients is, oh yeah, before I got diagnosed with MS, I could go 12 hours without peeing. Guess what? That's not normal. Okay. And so what happens is over time is their bladder eventually has a safety mechanism. We can't hold our bladders for that long. And so one day the bladder just says, I've had enough of you and your abuse, and it contracts and you leak. Okay. Then, because people are scared of that, they start going to the bathroom almost too often. So the pendulum swings the other way. They go from not going, for 10, 12 hours at a time to every time I feel like I have to go, or every time I see a bathroom, I'm going to pee just in case. Okay. And what happens then is that your bladder actually loses capacity. It becomes smaller the more often you do this. Okay. So what we have to do, and what I do from a PT standpoint, is we find the balance. Because you won't be able to feel your bladder fill as efficiently, you can't always rely on the urge. So I do what we call timed voiding. So I have people go to the bathroom every 90 minutes to 2 hours, depending on how they're doing, whether they need to or not. And that stabilizes it out. And then we can work on that urgency a little bit more. Then we do some exercises to work on it. But the big compensation that you have to make for MS with the urgency is just that you can't trust the urge. You used to be able to, and now you can't anymore. So now you just have to be a little more aware of how much time has passed in between when you went to the bathroom last. We'll also talk about some just good other habits that you'll practice while we're as we move forward. Frequency I kind of addressed also. So frequency generally I see more because people are afraid to leak than they actually have to go. Now, occasionally, it is an actual bladder problem. So there is a test that the urologists will do to see if that bladder muscle is getting a little spastic. So if you have spasticity in one area of your body, you can also have spasticity in your bladder. If you do have spasticity in your bladder, then we use a medication to help that, and it'll calm it down. Sometimes even if you go on other spasticity medications, it can also calm down what's going on in your bladder. But that is the one thing that we can't fix with medication or with exercise, and we will have to fix with medication. And then urge incontinence is when you actually leak when you have that urgency, and that's due to weak muscles, and that's due something that I can help fix with exercise. Just some other complaints. Hesitancy is a big one. So feeling like you can't start the flow of urine, so sitting down and you feel like you can't get things going. Interrupted stream or incomplete emptying. All of those things can be due to what we call a low tone bladder. So essentially what can happen is your bladder just stops contracting as efficiently as it used to. And we see this again, this correlates a lot. The more lower extremity paralysis you have, the more likely you are to have that low tone bladder. Unfortunately, there is not a whole lot we can do about that low tone bladder, and so that's sometimes where we will introduce something called intermittent catheterization, where we put a catheter in your bladder every so often to empty it because it's just not contracting strongly enough to get all that urine out. Double voiding is where you pee and then 2 seconds later you feel like you have to pee again. And that can be due to muscular stuff or that low tone bladder. Nocturia is getting up a lot in the middle of the night. So it is normal to get up once a night if you're under the age of 65. Lots of people think that that's not true, but it is. So normal once a night. Over the age of 65, it is normal to get up twice a night. And that's because as we age, our kidneys slow down with the production of a hormone that causes our urine production to slow down a little bit. And so we just produce more urine at night the older we get. Enuresis would actually be an issue with waking up and having peed in the middle of the night without you knowing. And that's generally a problem due more to sleep. So we can't rely on subjective history. As you've probably seen, when it comes to bladder issues, there's a lot of factors in there. And so often there are some things, if you come to see me first without having seen a urologist, there are some things that we'll talk about. There are some things that we can try to fix. I call it, kind of picking the low-hanging fruit. So we'll usually start with that, but then generally I will go ahead and send you to one of our urologists that actually specializes in neurologic dysfunction. And I cannot stress this enough. All urologists are not created the same. There are lots of urologists that do not have the background in working with patients with neurologic dysfunction. And so what I do, that's one of the reasons why a lot of times people will come to see me first, is because then I can kind of help them find somebody who's a little bit more, has more experience in that neurologic population. Because a lot of patients, over almost half of patients, will not have just a regular, or who have post-void residual, which is that little bladder scan that your neurologist might do. Some of them don't feel like they actually are retaining urine. The other thing that can definitely impact your bladder issues are relapse. So this is one of the few times when, even when we have a great bladder program going for you, and most of the time you are doing well, if you are in the midst of a relapse, your bladder will get worse, and that is normal. So one of those things that when I'm working with my patients with MS, I just tell them, during your relapse, we're going to just do comfort care type things. So you may have to get some pads, because you might leak a little bit more, but likely once your relapse kind of levels out, then either your bladder will go back to normal, or we'll be able to continue with your rehab program and get you back to that stable state. That post-void residual might be the only test that your neurologist will do, which is that bladder scan. And so that's why often we will send people to urology. When it comes to bladder dysfunction, I kind of mentioned, there are a couple of things that we can fix from a PT standpoint, and there's a couple of things that we can't fix from a PT standpoint. And so the things that I have listed there under muscle are things that I can fix with pelvic floor PT. So stress urinary incontinence is when you cough, laugh, or sneeze and you pee a little bit. That's usually due to that muscle imbalance that I talked about at the beginning. So I can help with that. Same thing with urge urinary incontinence. That's something that I can help with. If you're experiencing a lot of bladder pressure, that's usually due to a muscle imbalance, as well as pain or something we call pelvic organ prolapse that women will get. Things that I can't fix, things that I have to work with the urologist on. Pure urgency, where it's just that you have that urgency and all the behavioral things that we try don't work. That might be because that bladder is a little bit overactive. And so giving you some medication, in addition to the behavioral things that we work on, will help. Some urgent continence I can't fix purely with the muscle exercises. Same thing with pelvic organ prolapse. And the one thing I really can't fix is that bladder that won't contract, because that is muscle that is not under my voluntary control. It's not under something that I can do. And so if you need to cath, that's something that you absolutely will have to do. It's not something we can fix with therapy. Now, I would be remiss if I didn't talk about the bowel, because the bowel does affect the bladder. And so even if you're coming to me mainly with bladder issues, I'm still going to ask about your bowel. Why? Well, because your rectum is right next to your bladder. And so if your rectum is full of poo, your bladder can't fill up. You're going to have to go to the bathroom more often. So we will address constipation in addition to your bladder dysfunction, because that's not normal and it's probably impacting your bladder dysfunction. So constipation is the most common in patients with MS. Why is this? Well, a couple of reasons. One, you have to have good abdominal tone for stool to move through your colon really well. So if you have weak abdominals, you don't have good support for your colon. And so that's going to cause things to slow down. Another reason why we often see constipation, though, is as a result of those bladder issues. People have urgency, and so one of the first things that they try to do is limit their fluid intake, because they figure, well, if I don't drink anything, I won't have to pee. That's not true. Your kidneys are going to make urine whether you drink anything or not. So what happens then when you drink less is you become more constipated. We need water for that fiber that we take to work. And so those are kind of the main reasons why I see constipation in the MS population. But bowel dysfunction most often happens due to behavioral issues. Like I said, drinking less water. The other thing that causes constipation is just moving less. The more we are sedentary, everything slows down, including our gut. And so that's another reason why we see a little bit more constipation. Now, there are two types of dysfunction that lead to constipation. One is that the slow transit, so the things that I already mentioned, kind of moving things slowly through the bowel. But the other is something called dyssynergia. And all this is that our pelvic floor muscles are not coordinated. So if you've ever sat on the toilet and pushed real hard and nothing came out, that's dyssynergia. Your muscles are not opening up like they're supposed to in order to push the stool out. And so then it stays in there. And the longer it stays in there, the harder it is to push out. And so that's something that we can help from a pelvic floor PT standpoint, because that's a muscle problem. So that's something that I help you to learn how to open up those muscles a little bit better, how to push a little bit more effectively. And then we also go over some of those behavioral things that will help you in order to get your transit moving. Now, occasionally, if that dyssynergia goes on long enough, you can have something called an impaction, where the stool just gets built up in your rectum and in your colon. And if that happens, then we may have to try some enemas just to get you cleaned out before we can move on to any sort of pelvic floor muscle issues. And then the other thing that I just always mention from a pelvic floor standpoint for MS is sexual dysfunction. So lots of things that affect sexual functioning in MS, including the pelvic floor, but also fatigue, obviously spasticity and pain, bowel and bladder dysfunction, mood disorders, lots of different things that are going to cause sexual dysfunction. In men, we generally see erectile dysfunction when it comes to MS. About 9 to 10 years in is when we see that. And then in women, we see diminished lubrication, some sensory disturbances, not a whole lot of treatment for women with sexual dysfunction in MS. So I want to get and finish up with the physical therapy treatment when it comes to what I do from a pelvic floor PT standpoint. So the first thing is the subjective history. I'm going to sit down and I'm going to talk with you for quite some time, because I need to know, when did these problems start? One of the interesting things is bladder issues are some of the first precursors to MS. So sometimes these bladder issues that you think are not related to your MS were the first signs and symptoms of your MS. You just weren't having some of those other physical symptoms at the same time. But there are other things at play. So as I said, childbirth does affect those pelvic floor muscles. So for the women, what I am asking is, how many times were you pregnant? How many deliveries did you have? Were there any complications with those deliveries? Because even some of your problems may be due to MS, then you've got that other piece layered onto it. It's kind of like the orthopedic issues. So you've got MS and you start with weakness and then you break your leg. It's going to add some issues on top of it. So this is the same thing. For the men, I'm going to ask, have you had any prostate difficulties? Had you ever had prostate surgery or any surgery? Even things like hemorrhoid surgery can affect your bowel and bladder. So we're going to really extensively go through and try to figure out what is being caused by your MS versus what is being caused by the other things that went on in your life that could be, causing some issues. I'm going to talk about your primary symptoms so that I can start to figure out how much of this is the actual muscle versus how much of this is your bladder, and maybe we need to send you to a urologist. How are you dealing with your symptoms? What behavioral modifications have you made? I kind of mentioned that, I go to the bathroom every time I see a bathroom just in case. I know then that I'm going to have to try and walk back a few of those behavioral issues in order to improve your bladder symptoms. What medications are you on for your MS? There are certain medications for MS that affect the bladder a little bit more than others. And then there's some medications that we're not really sure how they impact the bladder. Ocrevus is a big one that we don't know how they impact the bladder. There's some really great studies being done on it, but we don't have any data. So I'll just look and see depending on what medications you're on. And then I'll look at your med list for other things too. So for instance, there's a lot of medications that cause constipation. So I'll kind of look through that and think, okay, maybe there are some side effects of the medications that you're on. We can't take you off those medications, but maybe we have to do some extra things to help those side effects. And then what medications have you tried for your bowel and bladder symptoms in the past? There are certain medications for the bladder that are better for those with MS. Unfortunately, what we find with the insurance companies, as always, is that they want you to try the cheaper medication first, have it not work, and then you can go to the better medication. So what we do is I work really closely with the urologists. We keep you on those bad medications for like a week, and then I write a really good note about how it didn't work, and then we get you on the better medication. So we try to work with them and figure out how we're going to get you on what you need. I usually will have you fill out what's called a bowel and bladder diary as well. It's not like, dear diary, today I felt better. But it's, telling me how often you're going to the bathroom, when you're going to the bathroom, how much you're drinking. It helps me determine, okay, is there behavioral issues? When is this worse? Is it worse in the morning, in the afternoon, in the evening? And it's going to help me tailor your program, your treatment program, to what you need, and any of the modifications that I might make. So this is kind of what a bladder diary looks like. I'm usually recording how often you went, did you have that urge, did you have any leakage, and how much fluid you have taken in. I do a lot of education, and so I'm going to give you a little bit right now just to so that you have a good idea of what some good habits are. 64 ounces of water per day, okay? That's about 4 bottles of water, and that's what everybody should be having. Lots of people drink too much water, so I'll get some patients that are like, oh, I drink a gallon of water. That's too much water, okay? But you also can't tell me, well, I drink 64 ounces of coffee and there's water in coffee, so that works. No, it's not the same, okay? Our body needs water. Scheduling. So like I said, you never want to go more than 2 hours without peeing. All right. So for some people, it's a little bit less, but 2 hours is a really good kind of basic guideline. You want to eat at least 30 grams of fiber a day, and most of us are not getting enough fiber. And so if you're not eating enough fiber, that's fine. At least take a fiber supplement then. There's lots of different ones out there on the market. There's fiber gummies, there's Metamucil. I would rather you get your fiber from food, but if you can't, at least try and take a fiber supplement. And then nighttime habits. So slow your drinking down about 2 hours before you go to bed. Make sure you do pee right before you go to bed. And then also about 2 hours before bed, put your feet up. Elevate your feet so that any swelling that might be in your legs or your feet comes out of your feet. From an exercise standpoint, we will talk about Kegel exercises. So that is the basic kind of tenet of pelvic floor physical therapy, but we're going to talk about other exercises too. So we're going to talk about core stabilization exercises. We're going to talk about what I call pressure management, being able to take a deep breath and be able to control your breath and your breathing so that you're not putting too much pressure on your pelvic floor. And then again, lots of different breathing exercises, which actually breathing exercises also calm down your nervous system, which can help reduce some of that bladder urgency that you'll have. Sometimes we will assign what's called a bowel massage, and this is just a nice little belly rub that can help improve the movement of stool through your colon. And so I'll show patients how to do that. I'll show caregivers how to do that if they can't do it themselves. We talk about toilet positioning, so trying to get on the toilet in a good position so that your muscles can work really well. Sometimes that's with a squatty potty shown here. Sometimes it's not. So we evaluate what's going to be your best push position and what gets you the most power in your push is what I always say. And so last but not least, we also just talk about mobility considerations. If part of the reason why you're leaking is that you can't walk as fast anymore and you can't get to the bathroom as quickly as you need to, maybe we need to talk about getting you a scooter or a mobility device just for in the house so that you can get to the bathroom. Maybe we do have to change your schedule a little bit in order to make sure that you're going a little bit more often. And maybe we need to look at your bathroom setup as well. Maybe we need to figure out what's going to make it easier for you to go to the bathroom. So that's just a little bit about pelvic floor therapy. My email address is there as well. And I am the pelvic floor therapist at Ohio Health, but I also have a great team with me. So even if I can't see you, you can see one of the wonderful members of my team. So thank you.
Thank you, Dr. Siracusa. So I have a few questions from online. Before I start running around to see you all out there, I just want to do the questions that came in online. So the first one is, are frequent UTIs prevalent in MS patients? And if so, why?
That's a great question. So sometimes, but what often a lot of people mistake a UTI for is that urgency. So there are lots of different things that go into a UTI. And so, once you have a UTI, then you're constantly afraid you're going to get another one. And so lots of people will misinterpret the fact that they have urgency as, oh, I'm getting another urinary tract infection. And so if that is the case, sometimes it's a matter of you're not emptying fully. And so that's going to be some medication that we're going to put you on. Sometimes it's toilet positioning. But I usually, at that point, I'm working closely with the urologist to see what's going on. Is there some issues with bacteria? The other thing that's really common is women, as we lose estrogen as we get older, it makes us more susceptible to UTIs. So that's another thing that sometimes urology will work on, is getting some supplemental estrogen cream to help with that.
Next question, can MS bladder leaks be stopped without taking a medication, an expensive medication?
Yeah, that's a great question. So it depends on why you're leaking. So if you're leaking because those pelvic floor muscles are really weak, then yes, that can be helped without medication. If it's because you have some spasticity in your bladder, unfortunately, the only thing that's going to help with that is the medication. So what I usually tell people, though, is try pelvic floor therapy. It's something that we'll take a look at, but we're also probably going to have the urologist do a couple of tests on your bladder to determine what the problem actually is. That's the worst part about bladder problems, is bladder is what we call smooth muscle, so it's not muscle we can control. And if the bladder itself is the problem, no amount of physical therapy is going to make that better. And that's the frustrating part.
Okay, thank you. And then from online, somebody writes, the closer I get to the toilet, the urge becomes even greater, and I'll leak right before getting on the toilet. Is this normal?
No, it is not. And so, yeah, that is urge incontinence. And so what happens is that the closer you get to the toilet, essentially your central nervous system starts sending signals from your spinal cord and your brain down to your bladder that says, we're getting close. You better hurry up and go ahead and start contracting. And so as you're pulling down your pants, everything starts going. So there's two issues there. One is weakness in those pelvic floor muscles. And then two is probably that bladder is a little bit too full. And so it can't really kind of hold, it's contracting before you're actually at the toilet. So we do two things with that. We do pelvic floor muscle exercises, and we usually start with shorter bladder intervals to almost do a workout for your bladder. So we have you go a little bit more often, and then we eventually stretch those intervals out.
Can you talk to us about pessaries and slings and when they are or aren't appropriate?
Yeah, that's a great question. So pessaries and slings are surgeries for women that have what we call pelvic organ prolapse. So what you have to think about is the vagina is a nice big long tube, okay? But it is also a stretchy tube. It can stretch too far. So once it stretches too far, it does not go back to its original shape and size. And so what happens with that is that then the organs like the bladder or the bowel or the uterus press on that stretchy tube, and they cause a lot of pressure and they cause a lot of pain. The pelvic floor muscles can help to create a little bit more support, but it depends on the level of that prolapse. So we grade prolapse on a scale of 0 to 4. When we start getting into that 3 and 4 kind of prolapse, that's when the muscles, it's gone past the point where the muscles can help it. And so pessaries are something, it's like, I call it like an ankle brace for your vagina, which is probably not the best description, but pessaries are something that you insert in the vaginal canal to hold it up. And then surgeries are to help kind of restore the normal tension in that vaginal canal. So really depends on the level of the prolapse, whether or not we recommend that surgery. And so again, we'll usually work with the urogynecologists on that.
If you have issues with both incontinence and hesitancy, is there like medicine or a treatment to help with that?
Yeah, so usually that's going to be a combination of medicine and treatment. So what we look, sometimes that hesitancy is just that the muscles are uncoordinated. So when they're supposed to be relaxing to let you open up and pee everything out, then they're not. And then the other thing though is that it could be that that bladder's not contracting as strongly as we could. So what we would do in that case is we would usually start on the basic exercises, and then I would work with the urologist. She would do the testing to see, is the bladder part of the problem? If it's not, then we can fix that with pelvic floor muscle stuff. Yeah, you're welcome.
All right. Next one online. Can urine urgency meds cause constipation or the feel of constipation?
They absolutely can. Unfortunately, the medications that we often give for your bladder, they do kind of dry everything up. And so what I tell people is if you have to be on those medications for your bladder, which sometimes you do, you want to take extra measures to help decrease your risk of constipation. So I will tell them to drink a little bit more water and take a little bit more fiber. And then we also may have them on something over the counter like Miralax, which can help decrease that constipation. It just helps your body hold on to the water a little bit more easily.
Okay. Last question online is, what recommendations do you have for nocturnal incontinence?
Yeah, so that's a great one. So there's a couple of reasons why you'll have nocturnal incontinence. So one is usually sleep problems. So what should happen when your bladder is full is that it should wake you up. But if you have untreated sleep apnea, if you were recommended to have a CPAP and you don't want to wear it, or you've never been tested for sleep apnea, that's going to cause nighttime incontinence. And so the first place we usually send you is the sleep medicine docs. The other thing that can cause it, though, is things like swelling, things like poor habits. So we will work on those. It's usually not a muscle problem when you have sleep incontinence, though, because if you think about it, you're not actively contracting any of your muscles when you're sleeping. You're relaxed, you're asleep. So it's usually due to those other factors.
Great. Thank you. That's a wrap.
Thank you, everybody. Thank you so much.
Thank you, Dr. Siracusa. I want to thank you all for being here today. We cannot do these programs without you. Again, I want to thank our sponsors, Novartis and TG Therapeutics, and we look forward to seeing you in October when we'll be back, but we'll be on the south side of Columbus, all right? Thank you. Have a great day.